Good morning. Welcome, everybody. My name is Eric Yen. I'm the Director of Marketing for Shield Healthcare. Welcome to our webinar titled Ostomy 101, Key Steps for an Accurate Stoma Assessment. Listeners will be in a listen-only mode. If you have a question, please type it in the chat box to the right-hand side of your screen. Participants are eligible for 1 CE credit. We'll tell you how to get that as soon as this webinar concludes. Your presenter today is Joy Hooper. Joy is a nurse entrepreneur with 20 years of experience working in a variety of hospital and in-home care settings. A graduate of Emory University CWOCN program, she has been certified as a wound, ostomy, and continence nurse since 2002. She is board certified by the WOCN as a CWOCN. At this time, I'd like to pass the presentation over to Joy. Joy, good morning.
Good morning, Eric. Thank you. Thank you so much. And I want to say thank you to Shield Healthcare for today's opportunity. You know, we couldn't be doing education like this today if it weren't for you being our partner. So thank you so very much. Now, if you're unfamiliar with where I work for the Wound Care Education Institute, and it was founded by 2 women, both nurses, with one idea. Now that's Donna Sardina right there on the left in that picture, and Nancy Morgan there on the right. And their goal for creating the Institute was to improve the management of wounds and ostomies for patients across the United States. And the Institute currently has 3 different certification courses. There's the Wound Care Certification course, the Diabetic Wound Care Certification course, and then the Ostomy Management Specialist course. And these courses prepare the healthcare professional, be it any level of nursing, a doctor, a physical therapist, or an occupational therapist, to sit for the National Certification Examination. And currently, the Institute supports more than 20,000 nationally certified clinicians nationwide. So that's a little bit about where I work. So let's get on with today's presentation of ostomy assessment. And we're going to have Donna Sardina online fielding questions for us. And I tell you what, if you don't understand ostomies, you are in the right place today, because we're going to break down ostomies for you so you understand it in a totally different way. And when you're doing that assessment, it's not going to be a problem for you. Now, when we start out and we're talking about ostomies, the term ostomy and stoma many times gets used interchangeably, but you'll see it's not. When you're talking about the ostomy, you're talking about what type of surgical diversion you had. Was it a colostomy, happening in the colon, or an ileostomy, happening in the ileum of the small intestine? It could even be happening, happening in somebody's trachea and be a tracheostomy. All right, so it depends on where the body is as to the term ostomy. Now, the term stoma, that's that red portion that you're looking at when somebody has a colostomy or an ileostomy. That's the opening itself, and it's made out of mucous membrane. So you see the terms get used a lot back and forth, ostomy and stoma, but they're not really interchangeable at all. Ostomy, you're talking about the type of surgery, and stoma, that's the actual opening. Now, there's another term that might be new to you, and that's effluent. Not affluent, but effluent. Effluent, that's talking about the output that's coming out of the stoma. And it can be fecal, it can be urine, it can even be mucus that's coming out of it. It could even be gas. Now, when we're talking about that diversion, we're talking about an alternate route for the stool or the urine to get out of the body. And so many times that's why they do these fecal and urinary diversions, just as an alternate way. Maybe the person's got a wound. They're trying to allow time for the wound to heal, so they're going to give them a temporary diversion. Or maybe this could even be a permanent diversion. But the diversion is simply an alternate route for the urine or the stool to leave the body. And that's typically why ostomy surgery is done. Now, when you're talking about the different types of surgeries, the different types of diversions, there's both continent and incontinent diversions. A continent diversion is an internal reservoir. So they make an internal pouch for the person, and the person doesn't have to wear the external traditional ostomy pouch, like you might be thinking a traditional ostomy pouch. Well, with a continent diversion, they have an internal reservoir, be it a Coke pouch or an Indiana pouch. It could even be a J pouch. But simply what that means is an internal storage, as opposed to an incontinent diversion where the person is going to wear an external device, a pouching system of some type, because it's incontinent, meaning the person is going to have no control over when the urine or the feces leaves their body. With a continent diversion, there's something that they do. They either stick a catheter in there to drain it, or they sit down on the commode with a J pouch and physically have a bowel movement. Well, with the incontinent diversion, like I said, that one, the person is going to require an external device. And when I'm saying an external device, I'm typically talking about the pouch. Some people call these ostomy bags. I prefer the term pouch. I just like the way that it sounds. There's no difference in the term bag and pouch. Same thing, I just happen to like the sound of pouch better. But what this is going to be used for is going to be to contain their gas, their urine, their feces. Most of the pouches are made of some type of plastic. You'll see some of them have different coverings on them so you can't see through them, but most pouches are made of plastic. Now, the pouch that I was showing a second ago was a one-piece system. A lot of people would prefer a two-piece pouching system, and so you've got your skin barrier, like you're looking at on the slide here. So this is your skin barrier, and it is what your pouch would attach to. Its function is to be adhesive, to attach to the body, and then to protect the skin. And then you've got the pouching system, and the two together make up your appliance. Now, for stoma basics, stool and gas are going to pass through the stoma rather than the person, sitting on the toilet and having a bowel movement. And although they have sensation in the skin that surrounds the stoma itself actually does not have the nerves in there that feel whenever the stool is being passed through. So it doesn't have the sensory nerves. It's also not going to be able to communicate pain. So many times stomas can get lacerated, they get mashed. However, the person doesn't feel anything, and that's because the stoma lacks those kind of nerves to be able to transmit those kind of impulses. Now, as I said before, the stoma is made out of mucous membrane, so it's always going to be nice and moist. It has its own natural lubrication, and you need the GI tract to be moist and secrete mucus. That's what keeps it lubricated, because what the GI tract does is it's pushing that food through your body is it needs to be lubricated, and its lubrication comes from this mucus. Now, when you have an ostomy, depending on how much of it is left from the stoma down possibly to the person's rectum, they can have a rectal discharge that's essentially just the mucus that's shedding off of the lining of the GI tract. The mucus can be many different colors. I've seen it anywhere from a clear to a light tan color. But some people can be concerned because they think, I'm wearing a pouch, I shouldn't have anything coming out of my bottom. But actually, many people have it a couple of times a week, some people every day, some people maybe once a month, and other people maybe once a year. They'll feel like they have a need to sit down and use the bathroom and expel this mucus. Now, the stoma itself is going to be very vascular. It's usually nice and red. That's the color we always want it to be. And so it's not going to be surprising when the person is cleaning around their stoma that they can get a little bit of blood on their washcloth. And a little bit of blood goes a long way on a white washcloth. So coming away with a little bit of blood, that's just fine for cleaning around the stoma. But there's a limit to how much we're going to call normal here. If they come away with a washcloth full of blood, or if there's bleeding that's coming out of the opening, the lumen of the stoma, they need to consult their physician, right away. All right, so we've talked about some terminology. Now let's get on into the assessment of doing your assessment on the stoma. And what you're going to do is you're going to get information from the stoma and that peristomal skin, and you're going to do it by looking at the stoma, by touching the stoma, by feeling that skin around the stoma, by listening to the person's vowel sounds, listening to what the person says about their stoma, listening to your colleagues, and listening to the caregivers. And then your sense of smell is used for your assessment as well. The reason that you do your assessment can be several different reasons. Maybe this is the first time you're seeing this person and you're trying to decide what type of pouching system is going to be best. Maybe the person's got some kind of problems and you're doing this assessment to identify the problems. Or maybe this is an assessment that you're doing to track the progress that the stoma is making. Maybe it's going through that shrinking period post-operatively. So you're looking for the progress of that stoma shrinking back down. The frequency that you're going to do your assessment is going to be based on your care setting, but typically in the immediate post-op period, we want it assessed every 4 hours for that first 24-hour period, okay? Now, if we could say the ideal stoma, what does the ideal stoma look like? Well, the first thing we'd like to say is we'd like for it to be moist. That's letting us know that mucous membrane is functioning just properly, nice and moist. Next thing that we would like in that ideal stoma is a round stoma. And why would we like a round stoma? Well, it works easier when you've got these little cards that you're using to measure your stoma. A round stoma works best to have that skin barrier pre-cut before it's sent to you. So there's advantages of a round stoma. We want that ideal stoma to be beefy red. That's letting us know that it's got good circulation. And we want the budded shape. Now, why do we want a budded shape rather than one that's flat? Well, you would like for it to be budded so when you put your pouching system on it, it protrudes into your pouching system and the stool will fall out, or the urine just falls out of it and falls down into the pouch. And that's so much better than it just oozing out of a flush or retracted stoma. It just makes it easier to manage. And talking about that protrusion, the ideal protrusion is about 2 to 3 centimeters. You definitely want 2 to 3 centimeters of flat surface surrounding that stoma. You want the stoma away from any belt lines, the umbilicus. You want it away from suture lines and any bony prominences. You would love to have the lumen centered up right in the middle. That's going to make it easier for that person to manage. And you want this ideal stoma located somewhere where the person can easily see it and reach it so they can manage it themselves. Now, when you're doing your stoma assessment, you want to be methodical. You want to set up your own system that works best for you. And if you follow your own system, you're less likely to leave something out. Most of us start in the center with the lumen of the stoma. We assess the lumen, the stoma, the border of the stoma, and then that peristomal skin. But like I said, just be methodical, figure out the way that you like to assess it best, and stay with that way, and you're less likely to omit something. In your assessment, you're going to mark the location of the stoma, which quadrant of the abdomen that it's sitting in. You're going to use these quadrants again when you're listening to bowel sounds as well. Now, location is very important. As I said before, you want it away from the umbilicus, you want it away from the belt line, the bony prominences, and we want it away from that skin fold if at all possible, because when these stomas sit in these skin folds, they can be more difficult to manage. All right, now let's talk about what type of diversion. Now, folks, to me, to really be able to teach ostomies to your patients, you want to make sure that you have a good understanding of what an ostomy is. So I'm going to take a minute here and look at some different types of diversions. I'm going to use this little apron here to explain it to you. Now, before I look at the diversions, let's take a quick tour through the GI tract. You chew your food and it goes down your esophagus into your stomach. When the food's in the stomach, it's held and stored and churned, and then it's slowly released to go into your small intestine. And as the food is making its way from the stomach into the small intestine, the pancreas, the gallbladder, the liver are all adding in additional digestive enzymes. So as that chewed up food is traveling around through your small intestine, it's getting melted down by those digestive enzymes. It's getting pulverized by muscular movement like peristalsis and segmentation, chomping it up. And it's getting pulverized in the small intestine so that the walls of the small intestine that are coated with those villi can absorb those vitamins and nutrients and take it to use for fuel for your body. So it's like saying the small intestine eats for us. Now, after that chewed up food has traveled through your small intestine, it's going to go into an area and enter the large intestine, also known as the colon. And just as the small intestine ate for us, the large intestine or the colon is going to drink for us. And it's going to do that by absorbing that liquid from that chewed up food as it passes around, goes through the colon, and then exits out of our anus. So that's a quick, brief tour of the GI tract and what's happening. Now, first let me explain a colostomy. With a colostomy, the surgeon is going to separate the GI tract. Now, they can leave a portion of it intact, and this would be known as the Hartmann's pouch, or it could be completely removed if necessary. For this demonstration, I'm going to leave the Hartmann's pouch intact. Now, I've got to do something because we've got food being taken in by the mouth, and we've got stool that needs to exit the body. So what the surgeon can do is form what's known as the stoma. On the outside of the abdomen, the surgeon is going to make a small incision into the person's abdominal wall. The surgeon will take the open end of the GI tract and pull it through that small incision on the outer wall of the abdomen, and this will be known as the stoma. This is where the stool is going to exit the body, and the person is going to wear a pouch over it to collect that stool. Now, that one was shown in the colon, so that type of ostomy procedure is a colostomy, the name taken from the colon. Now, if the entire colon was removed, the person would be left with their small intestine. And what's brought out for the small intestine type surgery is the ileum section, the very final section of the small intestine. So if the surgeon created an ileostomy, they're doing that same stoma procedure where they're bringing the end of the GI tract out. This time it's the end of the small intestine, the ileum. And this is how the abdomen would appear. We have a small stoma, lower right-hand side of the body, and this is how how the stool would exit the body. Now, both of those that I just talked about were dealing with stool. However, if we were talking about urine, we would be talking about having the kidneys, ureters, the bladder, and then the urethra. Many times if someone gets something like, let's say, bladder cancer, they have to have their bladder removed. And the surgery that's frequently done is called an ileal conduit. It gets its name from the part of the GI tract that's actually used to create the new reservoir to hold the urine. And that's going to be a section from the ileum. So what the surgeon would do is separate an ileum section from the GI tract and then reattach the GI tract back together. They'll take the ileum segment, implant the ureters into that new ileum segment, and then create the stoma again, usually on the lower right-hand side of the body. But this is where the urine would drain from the body. So it would come from the kidneys, down the ureter, into this new little conduit that was made of the ileum, hence the name ileal conduit, and then the urine would run right out of the body into a pouch. Okay. So that is some quick explanations of some different types of diversions that are frequently done for both fecal and urinary. When they create the stoma, you know, the surgeon's trying to create the best stoma, no matter if it's a temporary or a permanent procedure. They want the best type of stoma. And so whether it's temporary or permanent makes no difference in the surgical process. But many times you do see more loop stomas being fashioned whenever it's a temporary procedure rather than an end stoma. All right, now what am I talking about? Loop stoma, end stoma? Well, an end stoma is when the end of the GI tract is brought through the abdominal wall. A simple end stoma. End of the GI tract brought through the abdominal wall. So the end of the GI tract brought through the abdominal wall, folded over, that creates the stoma. Now there is another type of ostomy procedure that's done. It's called a double barrel. I see a double barrel done most of the time when it's a very, very small child, maybe a premature infant. With a double barrel, kind of gets its name from that double barrel shotgun, the surgeon separates the GI tract, and with a double barrel, you actually have two stomas. You're going to have a stoma, many times they can be separated, one on the right side of the body, one on the left side of the body. Or some surgeons actually bring the two openings bring the two ends of the GI tract out of the same opening in the body. But this could be a typical double barrel. Double barrel where you're going to have stool exiting through one stoma, and then mucus would be exiting out of the other stoma, because it's still another opening into the GI tract right there. So that is a double barrel. A double barrel, though, is an end stoma. The final type stoma I want to talk about is a loop stoma. Now, with a loop stoma, the surgeon is going to take a loop of bowel, bring it out onto the abdominal wall, and then the surgeon is going to have to keep that loop of bowel out somehow. So they use a stabilization rod, put it behind that loop of bowel to help hold it into place. Now, to be able to allow that stool to drain, they're going to bring the loop out, put the retention rod behind it, but they're going to make a split on that loop of bowel, fold it over, and the stoma can appear where it's easy to see the two openings that are created into the bowel. Sometimes the surgeons perfect it and bring it out where it looks like a little tube opening, like in the picture there on the PowerPoint presentation. Sometimes they make the stomas kind of sit and look like two end stomas. So there can be a lot of variables as to why a stoma looks the way that it does. Not only is it the person's body that we're talking about, of course, surgical construction has a lot to do with that as well. Many times you're going to see rods or stents that are going to be in place. The rods, like I said, with the loop stoma, help keep that loop of bowel from falling back into the abdomen. And what you're going to do is, while that rod is in place, typically 7 to 14 days, you're just going to be pouching around it. Try and pouch up underneath it if you can. If you have to, pouch on top of it. But when you're doing your assessment, you want to assess and make sure that the rod is not causing any kind of pressure injury on the skin, because it can put a lot of pressure on the skin. As far as the stents, you see those frequently with the ileal conduits or the urostomy surgeries, making sure all those openings and everything is staying into place. Sometimes when you're changing the pouch a couple of days after surgery, these stents will spontaneously fall out. Don't worry about it. Don't try and stick them back in. Just contact the surgeon and let them know that that stent has fallen out. When you've got the rod in place, when you're putting your pouch on top of it, do make sure that rod is centered. If it's off center and you set the pouch down on there, again, that can cause an area of pressure. If you had never seen one of those rods before, this is a good picture of the L-shaped rod. The L-shaped rod is used very frequently. It slides down underneath that loop. And then the surgeon can open the ends of it up. Sometimes the surgeons like to suture it in place just to make sure it doesn't fall out and to keep that loop of bowel from falling back inside the body. Now the stoma lumen. When I'm talking about the stoma lumen, what I'm talking about is the very opening where the stool is going to drain. You're going to note where that lumen is in your assessment. It's always nice when the lumen is right up on the top. That means the stool is going to come out of the stoma and drop down into the pouch a lot easier than when you're dealing with lumens that are on the side, like in these pictures right here. When the lumen shoots off to the side or shoots down to the bottom, many times that's just allowing that stool or that urine to run up underneath the edge of the skin barrier. And we hate it when that happens and contributes to leakage in our pouching systems. On your assessment, you can note where the opening of the lumen is by using the clock method. If you're using the clock method, you're imagining a face of the clock all around that stoma, just like you're looking at right there in the picture. Now, the clock in orientation to the person's body, the 12 o'clock is always going to be at their head, and the 6 would always be at the person's foot. So if you're looking at the stoma and imagine, okay, 12 o'clock straight up, 6 o'clock down toward the person's foot, where is the opening of the stoma in reference to where a clock would be? All right, so if we're looking at the picture right there, the opening for that lumen on that stoma is at the 6 o'clock position. So we would say that that lumen was at 6 o'clock. So this is just a good way to write where that opening is in your assessment. That's going to give everybody an idea when they read it of that exact location of that lumen. Color is very important to bring out in your assessment because the color of that stoma can tell us so many things about what's going on with the stoma. Is there good blood flow? Is there a possible compromise in the blood flow? You want that stoma to be nice and red. Many times a urostomy stoma is going to be more of a dark pink than a red, but that person is still nice and healthy. But if we saw a pink stoma or a dull red stoma and it was a colostomy patient, we might need to start thinking, okay, is this person anemic? Do they have a low hemoglobin? What's going on to cause this color? Now, other colorations that we can see on the stoma, we can see bruising. Many times that's a common complication that happens whenever we've got a rod in place underneath that loop stoma. So we can see bruising. Another thing that we can see is whenever there's a lack of blood supply, we can see that darkened blue or purple color, and that's not a color we ever want to see. So whenever you see that brown, that blue, that dark black or dull color, what you want to do is put that gloved hand on that stoma and feel that stoma. Does it feel warm? If it feels warm, that's good. Maybe what you're feeling is a warm stoma that's perfectly viable, but it's got what's called melanosis coli. Melanosis coli is a benign condition that somebody develops after they've been using a lot of laxatives, and it gives a different color to the lining of the GI tract and makes the stoma more of a brown color. So it's a benign condition. The stoma should still feel kind of like a large marshmallow, nice and spongy. It should be viable, it should be moist, and definitely it should be warm to that gloved hand. Now, in the lower picture, what you're looking at is a necrotic stoma. So I would expect when I put my gloved hand on this stoma for it to feel cool, maybe even cold. It's probably going to be dry, and possibly when I remove my gloved hand, I could be taking some of that stoma off with it. And so if that does happen, I'm going to look back down at that stoma. Do I see any red up underneath it? This would be a time that if I saw bleeding, bleeding would be a good thing right here. Let me know that there's some viability up underneath there. Because typically when we see that dark, dry stoma, we're thinking necrotic, non-viable, not a good thing. The stoma should always be moist. Like I said, it's a moist membrane, a mucous membrane, so it should always have its own natural lubrication. Stomas can appear so many different ways. Depending on what part of the GI tract was used, and is it going to be a part that was very textured? Are we going to see a lot of grooves, a lot of creases, like the one in the top picture? Or is it going to be more smooth, like the stoma in the bottom picture, which very well could be one of these loop stomas that you're looking at, and it's just that puffy, swollen top of it. And then so the openings would be right down here on the side of it. Stomas can appear just all different ways. They can be round, they can be oval, excuse me. They can be very irregular in size, and it has to do with, like I said earlier, surgical construction, the type of ostomy that they're doing as opposed to a small intestine or a large intestine, and also the person's body composition. And the person's body composition is one thing that's frequently overlooked when you're trying to explain to that person why their stoma looks, you know, particularly one way or another, such as why does it protrude, or why is the stoma more flush with the skin. So let's consider the GI tract again. And when you're talking about the GI tract, we're going to talk about how the body composition is affected, or how it affects the look of that stoma. So if I have adipose tissue that I've got to think about going through, you know, the surgeon's going to make the opening into the body and go through multiple layers. He's going to go through the skin, and he's going to go through a fatty adipose layer. Well, depending on how much adipose is on the person's skin, is on the person's body, that's going to affect the outlook of that stoma. So the surgeon separates the GI tract, and as they try and pull that GI tract through that adipose or through that fatty tissue, well, the GI tract, it's not like a water hose, and the surgeon can just separate as much of that GI tract as they would like to be able to pull it through the front of the abdomen. That surgeon has got to keep that GI tract attached to the blood supply. And so they're not going to have nearly as much to be able to pull through and create a nice protruding stomas. So many times somebody with a lot of adipose tissue, your obese or your overweight patient, they're going to end up with that flush or retracted stoma. Many times the skin is going to have multiple creases and divots, and that's just from that surgeon having to possibly push down on the skin while they're pulling up and trying to mobilize as much of that GI tract as possible, yet keep enough of it there to keep it viable. And when the skin is creased and has ridges, many times that person is going to have to use that convex pouching system, the one that's more bowl-shaped on the back, as opposed to using a flat pouching system on the back. So it could set that person up to have to use more accessory products as well. So now you see that the body composition, surgical technique, and the part of the GI tract that's used to create the stoma all go into the what the outcome of this stoma is going to be. You see, stoma protrusion is very important. I like to explain it to my patients like this. Many people, when they have their stomas, they say they've got innies, stomas that stick in, or they've got outies, those stomas that protrude. And sometimes people don't want to see that protruding stoma on their body. They think that it just doesn't look good. I explain it to them the same way you're talking about your water faucet on the outside of your house. Think about your water faucet. It's on the outside wall of your house, and it's shooting the water out away from your wall. And that's what you want your stoma to do. And that's what a protruding stoma can do. That protruding stoma is going to help push that stool or that urine out and fall down into the pouch, the same way the water faucet shoots it out off of that wall. The last thing that you would want is, instead of having a water faucet on your outside wall, just an opening where water is just going to run right down the wall of your home. You would never want that. And that's kind of how a flush or a retracted stoma can feel like on that person's body, that the urine or the stool is constantly wanting to run back up underneath that skin barrier. So know that the protrusion of that stoma can make life and management of an ostomy a lot easier, or it can make it a lot more difficult in many cases. So if the stoma didn't protrude, if it was at skin level, we would say that it was a flush stoma. And of course, if it was concave, we're going to call that one a retracted stoma. If it moderately protrudes, if it protrudes too much for that person to be able to manage it, to be able to conceal it, if perhaps they're having an issue of their pants, causing friction damage to it, they may even have to have part of it amputated away. But I would certainly rather be dealing with a stoma that protruded rather than one that was flush. It's just, it gets to be a point where it protrudes too much, you're actually starting to talk about a prolapse stoma. And this is what a prolapse stoma would look like. With a prolapse stoma, what has happened is your stoma is telescoping from the inside out. So it's getting longer from the inside out, and so since it's getting longer, it can also get a lot wider because it's telescoping out. It's not like it just came loose and fell from the body. It's turning inside out, and these can start to look quite swollen as well and take up a lot of room in that pouch. And when they're taking up a lot of room in that pouch, there's not more room for the stool or the urine to go, and it gets harder to manage. As I've said before, the size of the stoma is going to have a lot to do with what part of the body was used to create the stoma. Was it from the ileum, small intestine, so it's going to be a smaller stoma, or is it from the colon, in which it could be a larger size stoma? A ureterostomy is a stoma that's created from the ureter, and they don't do many of the ureterostomies because they say that those types of stomas tend to stenose. That means get smaller and get harder, and so they just don't work out as well. So that's why we see more of the ileal conduits done as the urostomy procedures. When the person is going to measure their stoma, they can use these little cards that are sent out by the different ostomy manufacturers. These come in the packets of the skin barriers, and they can use these little cards to find the right opening around their stoma so they can find the perfect measuring for it. So with these little cutout openings, make it very easy to measure. If you don't have the little card that has the little pre-cut openings, you can simply measure from one side of the base of the stoma to the other side of the base of the stoma. The stoma is going to shrink in that first 4 to 6 weeks right after surgery, and so we need it measured frequently, just so the person's not cutting out that opening too large. They want to cut the opening out that's going to go around that stoma. They want to cut it out about 1/8 of an inch larger than the stoma. You only need about 1/8 of an inch in between the edge of the stoma and the edge of that skin barrier. You want it close enough to be protecting that peristomal skin, but you want it far enough away that if the stoma were to move with peristalsis, get bigger or get smaller, then as it's getting larger and smaller and moving away from the side of that skin barrier, you don't want it rubbing up against it and having any friction issues. Now, many times after somebody's had ostomy surgery, they are all ready for that effluent to come out. And with the colostomy, they lay there the day after surgery, and then they'll lay there the day after that, still waiting for that output. Well, they don't need to worry, because that output from that colostomy may even be up to 72 hours after the person has had surgery. Typically, that first drainage with that colostomy is going to be serosanguinous drainage, and then as that person starts to eat and becomes mobile, the food is going to, the output is going to start to thicken up, as I said, if they started taking in more food. But just remember, with a colostomy, it can be 24 to 72 hours before they finally have any output. It shouldn't be that long with an ileostomy because the stool doesn't have as far to travel. That output from that ileostomy post-operatively is usually going to be about 12 to 24 hours after surgery, and that first output, it's not going to look like stool. It's going to be dark green in color. It's going to be thick and viscous and odorless. It's not going to smell like stool. And then again, as the person starts eating and becomes mobile, then that output is going to start thickening up. Now, in your assessment, you want to note, number one, is the stoma functioning or is it non-functioning? If it is functioning, you want to note the consistency of that output. Some good words for that output. Is it thick? Is it viscous? Is it liquid, oily, pasty, form, tarry, thin, bloody? Those are all really good terms to use to talk about the consistency of that output. Now, with the urostomy stoma, one thing that you've really got to watch out for is that mucus that's going to be in that output. And that's because that small little section that was used to create that stoma, that small little section came from the GI tract. And the GI tract is always secreting mucus. Now, with an ileal conduit, that small little piece of ileum was moved from the GI tract, and it's now part of the urinary system. But that little section of GI tract doesn't know that. It's still going to secrete mucus just like it was still part of the GI tract. So as that urine runs into that little segment of small intestine, this little segment of small intestine is still sloughing off that mucus, and that can show up in that urostomy pouch. So that output is going to be immediate. That output can be blood tinged in that first 24 to 36 hours. And that can be, something that's scary for that patient, but the patient needs to be told that's just fine. And it can have those long mucus sheds in there. Well, the mucus sheds are probably always going to be there because of that little piece of GI tract. It's probably always going to be secreting off that mucus. Make sure that person knows that's fine. That's just letting them know that little section of GI tract that's now part of the urinary tract is nice and healthy and doing what it's supposed to do. What they do want to note with that effluent from the urostomy is the volume, how much urine is coming out, the consistency. Is there mucus in it? Are there crystals? Is it gritty? Is it cloudy? What's the color? Is it straw colored, amber? Is it more blood tinged? And note if there's an odor or not, a presence or an absence of an odor. And if there is an odor, what does it smell like? Is it like ammonia? Is it like acid? Is it more fishy or fruity? Those are great words for your terminology as to what the odor might be with that urostomy. Now, don't forget, you want to note whether it was functioning or non-functioning. Sometimes the stoma just is not functioning yet, and so in your assessment, you're just going to say non-functioning. It can also be just only passing stool. Another thing that you want to make sure that you're noting in your assessment is that mucocutaneous junction. The mucocutaneous junction, that looks like a long, complicated word, but when you break it down, mucosal tissue, we're talking GI tract, cutaneous, that's just the skin. So mucocutaneous is where the rubber meets the road here, where the GI tract is sewn onto the skin. Right after surgery, the person is going to have sutures right there in that area. So you just want to treat that area as a wound. You want to be assessing it, making sure those sutures are intact, making sure that it's not pulling away from the skin. And sometimes we see that happen. And it's a common occurrence with ostomies where you're going to have some varying degree of mucocutaneous separation right there at that junction. Ideally, there should be no difference in that surrounding skin right there in that peristomal skin area and the skin anywhere else on their body. When we talk about the peristomal plane, we're talking about the area of the body where that skin barrier is going to sit. And you know what? For somebody with an ostomy, the peristomal plane is one of the most important locations on their body, because we want this peristomal plane to be as free of creases and scars and skin folds as possible. You also want this peristomal plane to be nice and clean and dry when you're applying your next skin barrier to it. That peristomal plane should look like any other skin on the person's body, shouldn't be any different. In your assessment, you're going to be looking for color discoloration, like, is it dusky? Is it red? And if it is red, where is it red? Is it right next to the stoma? Is it out away from the stoma? Because when you look at the top picture, I'm thinking, you know what? whatever kind of skin barrier this person used, it looks like it might be that taped edge that was really irritating their skin. So possibly if they had a skin barrier that had a taped edge, I would want to choose a skin barrier that only used hydrocolloid on the back, and I wouldn't be using any tape around the edges of it. So you can see erythema. You can also see bruising, and we can see staining of the skin as well. Sometimes the different products that we're using on our skin in turn stain the skin. It's a benign condition, but many of them do stain the skin. When you're doing your assessment, you want to look for the peristomal skin integrity. And when I'm looking at this picture, it looks like the ring of fire. And what do we know about the ring of fire? It burns, burns, burns. And that's what that skin does around that stoma right there. It burns because this is the equivalent of a burn. This is a partial thickness injury. And what do we say about partial thickness injuries? Partial and painful. This is a very painful area right here. The skin is raw, and you know what? We got to come back and put a pouching system right on top of that raw skin. Luckily, the backs of these pouching systems provide the best environment for open areas around the peristomal, around that stoma to heal up. The last thing you want this person that has this much peristomal skin irritation to do is not put a pouch back on, to just try and put paper towels over it. I hear people say they want to do that all the time. They just want to sit there and put a paper towel over it. No, don't do that. Put a pouch on there. Put a pouch on there. Protect that skin. Don't allow the effluent to get on it, because when that effluent gets on the skin, it breaks that skin down. And that's what it looks like it happened in this picture. It looks like they were cutting the opening too large. The stool was just sitting there on top of it, and it broke that skin down. Another thing that you want to look for when you're checking that peristomal skin is, remember the rod that I talked about? Well, that rod can do some damage, and that's what we're looking at in these pictures right here. The rod has done some damage, created a pressure injury on the side of that stoma, and that is just a wound now that we're going to have to take care of up underneath the skin barrier. Other things that we're going to be looking for: lesions, ulcerations, incisions, and scars, anything in that peristomal area that can cause us a problem. Wrinkles in the skin, indurated areas, that weak, flabby abdomen. Those can be areas that are difficult to pouch. So we're paying close attention to that in our assessment and noting, is this weak skin, flabby skin turgor? Is it weak abdominal muscles? Because that's going to help us choose the next pouching system, the back of it. Do I want something firm or do I want something soft? Now, stomas aren't going to feel pain, because like I said earlier, they lack the nerves that transmit the pain impulses. But that surrounding skin does feel a lot of pain, all right? So, as I'm summing it up here, we've got to think about a good stoma assessment. That's going to be the foundation of your ostomy care and management, because you've got to know that stoma that you're dealing with to know what kind of pouching system is going to be working best for your particular patient. So I'm getting ready to turn it back over to Eric, but before I go, let me give you a little bit of housekeeping here on how you're going to be able to receive those continuing education credits. Now, for those of you that are online, you've already signed up here. You're going to receive an email. It's going to look like the picture right there in that top right corner. You should receive this email by maybe Tuesday the 25th, if not sooner. And if you don't receive the email by then, check your spam folder. So you're going to get the email, you're going to click the little evaluation link, answer a couple questions, submit it back to WCEI, and then you're going to get a second email that's going to include your certificate. So that's of you that have already signed up for the email, for this webinar. For those of you that are sitting in groups with your group leader, you can download the webinar viewing packet, fill out the sign-in sheets and the evaluation forms, fax them in to the number seen on the screen back to the WCEI, and then you'll receive those continuing education credits in about 7 days. And if you know anybody that missed today's webinar, they can catch the replay because we have recorded the PowerPoint presentation and the audio. And this PowerPoint presentation will be available free in about a week from the WCEI's website. That's WCEI.net. So now I want to thank you very much again for coming and listening to the webinar. And I want to thank Shield Healthcare again for being our partner and helping us do this. And so, Eric, I'm going to turn it back over to you.
Great. Thank you, Joy. That was wonderful. We got time for a few questions. If you have a question for Joy, please type it on the question box to your right. And while we wait for questions, a couple of housekeeping items. So you can catch the recording on WCEI. You can also catch the recording on our Shield community page. It's www.shieldhealthcare.com/community. And we'll have the recording there hopefully by this afternoon or tomorrow. Joy, we've got a bunch of questions regarding your apron. Everyone is dying to know where to get one just like it.
Oh, can you still hear me, Eric?
Huh?
Okay, this apron is something that I teach with. I actually invented it after I had started working in acute care. I started looking for a visual to be able to explain ostomy surgery before, during, and after surgery. And I ended up inventing it, and I patented it, and I actually sell it from a website. The website is apronsbyjoy.com.
We've got a lot of comments regarding your apron, at least 50. This is the best explanation I've heard. Thank you. So that's a lot of positive comments regarding your apron, and I have to say it's a wonderful teaching tool. A question here, actually Donna's been great about answering the various questions during it, but I figured I'd open it up to the whole audience just in case they had those same questions. What are indications for each type of stoma?
Well, you know, let's say a colostomy. If somebody had a low rectal cancer and had to have their rectum removed, many times they would do a colostomy procedure. The surgeons always want to leave as much GI tract as possible. So they want to do these surgeries as low or as far down in the GI tract as possible. So by far, they would rather give somebody a colostomy than an ileostomy, because if you've got your colon, you've still got that part of your body drinking for you. So it could be diverticuli, and I am seeing people having colostomies for diverticuli in a lot younger age group. Over the last couple of years, I've had people in their 20s and in their 30s that are having these temporary colostomies for diverticuli. I didn't see that 10, 15 years ago, but we're seeing diverticuli in a younger population. So that could just be some reasons, maybe even ulcerative colitis. They might have to have the end section of their rectum removed, and so they could end up with a colostomy. And then if they had to have their entire colon removed, then they would be left with the small intestine, so that would be your ileostomy, coming off of that, the ileum section of the small intestine.
Great, thank you, Joy. We deal with a lot of patients with J pouches. Can you explain the J pouch with the apron? Is that possible?
I don't have the attachments with me to do a J pouch. You're going to have me back, Eric, and we're going to have to do a demonstration on what are all these different procedures. But with the J pouch, what they do is they remove or bypass the large part of the intestine, the large intestine, and they take the small intestine and the last section of it, the ileum that I was working with to make the ileostomy, they form an internal pouch. They make an internal reservoir to hold the person's stool. And then they form this pouch and connect it back down to the person's anal sphincters. So they don't have a stoma, you know, where that stool's going to come out. It's going to be connected back to their anal sphincters. And they're going to sit down on the toilet and go to the bathroom spontaneously like they did prior to surgery. The difference is they don't have that colon that's going to be absorbing that fluid and making that stool more firm. So the person with a J pouch is dealing with the output coming right out of the small intestine. Now, that means they're going to be dealing with very liquid and very mucus-filled stool that also has a lot of those caustic enzymes. So many times the bad part of the J pouch are those caustic enzymes making that person's bottom just really sore and raw.
Great, thank you, Joy. With a protruding stoma, what is the best form of treatment?
You know what? It depends on how much it protrudes, because if it just sticks out a little bit, honey, let it stay. Let it stick out a little bit. Maybe if they need a guard to protect it, there's different guards out on the market. But unless it's prolapsing and causing problems, typically nothing is done. Now, if it's prolapsing and causing a lot of problems, they may simply do an amputation where they amputate the end of it off and you end up with a smaller stoma. Or the surgeon may need to go back in and they operate right next to the stoma. And what I don't usually like about that is many times it's creating that uneven area in the peristomal plane. But that's typically what's done. Sometimes when you have that prolapsed stoma, there's a good old ET trick where they sprinkle granulated sugar on top of the stoma, and it creates an osmotic gradient and just makes it shrivel back up. Kind of like putting salt on a slug, if you ever did that as a kid, but this makes it retract in a therapeutic way.
Great, thank you, Joy. Have you heard of an Indiana pouch?
I have. An Indiana pouch is an internal pouch that would be for storing urine on the inside of the body. So that's an internal reservoir for urine. Instead of the person having a urostomy, this is an internal pouch that they're going to use a catheter and drain, and they're going to irrigate it, and usually about once a day they're going to irrigate the inside of that pouch to rinse out that mucus. But a lot of people have these internal pouches and absolutely love them, absolutely love them. So it's just another internal pouch.
Great, thank you. There's so many great questions. I apologize, we only have time for a few more. Joy, can you explain more about the ileoconduit? What is the indication for it?
Okay, the indications for an ileoconduit, that is a urostomy. You know, the name comes from ileal, the small intestine, ileum section. Conduit, they're simply taking a small section of the ileum and making a conduit. A conduit is something that carries something from one place to another. So they're making this little piece of ileum a conduit. They're attaching the ureters to it and bringing it out of the body and making that stoma. The reason somebody would have that procedure, maybe their bladder just quit storing for them, you know, and it quit functioning as a storage area, or maybe they've got bladder cancer and they've got to have their bladder completely removed. So those would just be a couple of indications, you know, why somebody would want an ileal conduit.
Great, thank you, Joy. I know you said you utilize the duoderm portion of the appliance to cover irritated skin around the stoma. Do you ever recommend any type of treatment / paste to soothe the excoriated or partial thickness breakdown?
You know, typically I don't use paste whenever the skin is denuded or raw. What I usually want, as crazy as this is going to sound, if it is just raw skin, I want that good pouching system back on there. Because the backs of these, you mentioned that name Duoderm. And Duoderm is from one of the companies. It's a hydrocolloid, you know, a gummy-like dressing. Well, the backs of these skin barriers are made out of something very much like that. They've got hydrocolloid in them. So if you can put a pouching system on there, Eric, you're creating an environment for that raw skin to heal. And Eric, that's what it's all about, is creating that environment so that raw area can heal. That's what it's all about. And what you want is a good fitting pouching system over there, providing the environment for that peristomal skin to heal, you know, that raw skin around it, allowing an environment for that to heal, and you're keeping that stool contained in the pouch. So that's why I say keep going for that proper fitting pouching system.
Great. Thank you, Joy. That's all the time we have for questions. I apologize. There's so many great questions. We'll try to answer as much of them offline. Joy, if I could get you to advance to the next slide.
Sure will. There we go.
I encourage all the participants to check out Ostomy Life. That is our community page specifically for ostomy. It has great resources and blogs and videos regarding things like how do I travel with an ostomy, how do I sleep with an ostomy, how to tell a loved one about an ostomy, ostomy misconceptions. So I encourage you to log on to shieldhealthcare.com/community/ostomylife. We have an Ask Laura feature where you can ask Laura. She's one of our ostomists. She's wonderful. You can ask her anything regarding her ostomy or things related to ostomy, and she should get back to you in a few days. So again, this is recorded. If you missed any portion of this webinar, you can come back to shieldhealthcare.com/community for the recording. Unfortunately, we are unable to hand out the actual PowerPoint. It is proprietary to WCEI, but if you miss any portion of it, you can go back to the recording. So I'd like to thank Joy. Joy, thank you so much for that wonderful presentation. And I'd like to thank all the participants who participated with this webinar. Thank you so much. Thanks, Joy. Thank you, everyone. Have a great rest of your day.
Thank you.
Thank you.